The Limi Children Hospital is a multi-specialty children hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.
Good afternoon, live and online audience. I want to welcome you again to our monthly webinar from the Limi Children's Hospital. So if you have, let's just do a little housekeeping. If you have any questions, you can drop them in the chat box or the Q&A section so that we can tackle them as the presentation goes on. So for those that just joined us, I think we need to reintroduce ourselves again. With me on this jolly ride is
Dr. Chukwumeri Dechidima
and my humble self, Dr. Mwala Gabriel. So we are consultant pediatricians in Limi Children's Hospital, and we'll be discussing neonatal seizures. Okay, so the Limi group, it's 40 this year. Since February this year, we marked our 40th anniversary. So this journey didn't just start now. It's been, decades, like 4 decades of quality healthcare. Now, Limi has vetted 3 bouncing children, the multi-specialist group at the central area, the cardio care multi-specialty hospital, internal medicine, interventional cardiology, where we have our cath lab, dialysis, cardiology, and other subspecialties in internal medicine. Then we have the Limi Children's Hospital, where this presentation is coming from. Now, in Limi Children's Hospital, we are not just like every other hospital. From neonatal intensive care to interventional, to child neurology clinics, developmental clinics, adolescent medicine, general pediatrics, all the possible pediatric care that money can afford is available here at Limi Children's Hospital. So sit back while we take off on 1,000 feet above sea level. Just fasten your seatbelts and enjoy the ride. Okay, so we've already mentioned some of the things that we do here. Pediatric cardiology, we have a pediatric cardiologist that doesn't just do echo and tell you the diagnosis. We actually follow through to, corrective surgeries and post-surgical care. And we have a lot of good, results or good reports from the parents of our guests that have been managed there. Pediatric nephrology, endocrinology, neonatal intensive care with transport incubators that can, take preterm neonates from wherever sister facilities, they are delivered down here for excellent pediatric care. It's equally available. We also have pediatric neurologists, that have been able to manage a lot of our kids with developmental challenges, seizures, and all. And we've been getting lots and lots of referrals from centers within and outside Abuja, and the results have been encouraging. So go to the next slide. Okay, so our my colleague will introduce our topic for today.
Okay, so today we'll be discussing neonatal seizures. How can we recognize them? And then how do we manage these neonates, these newborns that have neonatal seizures? That will be the anchor of our discussion today.
Okay, so it will be our expectation that by the end of this discussion, our participants will be able to recognize neonatal seizures when they find one, be able to relate some neonatal seizures to possible underlying etiologies, as well as being capable enough to know how best to manage these seizures when they present to us.
So we'll use the following outline to discuss this. We'll have a case and then introduce, classify. We'll talk about the pathophysiology, possible causes. How do we investigate these children? What's the treatment for neonatal seizures? How can they be prevented? And then we'll conclude.
Okay, we'll start off with a case vignette. This 33-year-old male neonate was rushed into a facility from a peripheral non-specialist hospital here in Abuja on account of poor cry at birth. Child was equally presented with difficulty with breathing, as well as generalized clonic seizures. Now, these seizures were noticed, 16 hours prior to presentation. This was roughly 22 hour at 22nd hour of birth, and the seizures being multiple, associated with fixed upward gaze, and lasted for 2 minutes and aborted spontaneously. It was garnered that the child was delivered via spontaneous vertex to a primiparous 24-year-old civil servant after a prolonged obstructed labor of 3 days. The child at presentation appeared dusky, was grunting, in severe respiratory distress with chest indrawing, with irregular efforts at breathing, and the oxygen saturation was 40%. In addition, the random blood sugar that was done was unrecordably low. So at this point, we want you to, just have these teasers. From the case presentation, what do you think were the possible causes of these the seizures that the baby presented with? What could be the 3 management modalities that could be offered this child, as well as the 3 possible preventive measures that, if applied, could have prevented the consequent presentation with such symptoms that we saw. So if you have the answers, you can just put them up in the chat box while we talk about them as the discussion continues. So let's check whether there are some, okay. No answers yet. Okay, so while we wait for the answers, from our participants, let's just have a look at this video. These are some of the ways our neonates, can actually present when they have neonatal seizures. That the guy that is raising hand, just need to put up his questions in the chat box. Okay. The video has. Okay, I think we're already having some questions. So the chat is disabled. Pamela, you said the chat is disabled. Can you help us, sort it out so that those that want to put questions can put it up? You said the chat box is disabled. Okay, so while we wait for the questions or comments. Okay, they said it's disabled. I don't know. Okay, okay. Can I? Everyone. Is it okay? Okay. Okay. We just noticed. Okay, we just noticed that some you are finding it difficult to drop comments on the chat box, so we can actually put them on the Q&A section of the webinar. Just put your answers or questions there. We'll be able to see, and okay, we've already seen Pamela putting up a chat up there. Okay, okay. So, okay, we are getting some, okay, beautiful. Peter has given 2 possible causes of the seizure: hypoglycemia, neonatal sepsis, very correct. Perinatal asphyxia, correct. Hypoxic, oh, very wonderful. So we already have more than 3 possible causes of the seizures. Beautiful. We have a very active and highly cerebral audience. This is encouraging. Okay, so we move on. Let's try to define seizures. When do we say neonatal seizure has occurred?
Okay, we say that a unit has had a seizure when there's a sudden paroxysmal or abnormal alteration of electrographic activity at any point from birth to the end of the neonatal period. That's in the first 28 days of life. That's for full-term babies, or to the end of 44 weeks post-conception for the preterms. as when you now say the baby has had a neonatal seizure. So at that point, once it's a sudden and it's paroxysmal, that it's occurring repeatedly, and it's an abnormal occurrence, you say that the baby has had a neonatal seizure.
Okay. Okay, so let's go to the next slide. So that means if a preterm that was delivered at 32 weeks, presents with seizure, at any time up to the 44th week post-conception. That means the child, even if the child presents with seizures, for instance, at second month of life, is still neonatal seizures because the child has not attained up to 44 weeks post-conception. Okay, so by way of introduction, seizures, the reason why we had to present this is, when it comes to neurologic dysfunction amongst this group of, children, seizure is the most important indicator of an underlying neurologic anomaly. So we need to be able to identify them and be able to offer them some help, because if it's not identified early, they may come down with some neurologic sequelae that might be so distressing for both the healthcare worker and even the parents. It could be so worrisome. So we need to know those that are actually presenting with seizures by way of knowing some of these subtle ways that these neonates can present. And neonatal seizures have been found to be more common. Seizures in children has been found to be more common amongst neonates than in older children, and they tend to occur more in very low birth weight, neonates than their adequate, normal, appropriate weight for gestational age, counterparts. Those that weigh less than 1.5 kg at birth have incidence of as high as 57.5% per 1,000 births, when compared to those with normal birth weight of between 2.5 and 3.9999, let's say 4 kg, that have a lower incidence of 2.8 per 1,000 births. So this draws us to, cause us to, pay very close attention, especially for our preterm babies, because they have so many factors. Their odds against them, is quite high. So we need to really, be on our guard when they do present. Okay. For the pathophysiology, the neonates have a hyper-excitable brain. Their brain being immature means that, all the channels like the sodium and potassium ATP channels, having been immature, can easily be excited by any abnormal metabolic or whatever functional anomaly that happens. They will tend to throw an abnormal discharge. So the other things that have been demonstrated are increased density of some receptors like NMDA and AMPA receptors. Now, this AMPA receptor is responsible for, allowing calcium in and out of the cells. And that when, in the action potential for there to be contraction, for instance, there has to be movement of calcium into the cells. So if these receptors are immature and allows for easy passage of calcium. The same thing that you find in, a cell that has been excited, you now find it occurring just with minimal or no stress at all. So this is one of the reasons why their nerves or their neurons, I mean the neonates now, is hyperexcitable. And one of the things that has really shown that the density of the AMPA, receptor plays a key role is the use of topiramate. Topiramate is an inhibitor of AMPA receptor, and it's very, very good. Most seizures that are recalcitrant to other anti-epileptics, once you give them topiramate, you see that there will be very good control of the seizures. So that goes to show that the underlying pathophysiology is some of these receptors that are either having delayed maturation or are increased in density. Now, the inhibitory hormones like GABA that have not been matured enough to prevent the ones that are excitatory from firing without any control, has also been implicated in the pathophysiology of neonatal seizures. So most drugs that are given to control seizures in neonates target these receptors. So that can help us know how best to channel our treatment modalities when they do present to us.
So in neonates, really, the seizures can be classified as either subtle seizures, as in they don't present like typical seizures that we know of generalized tonic, clonic nature, or they could be focal clonic, where just a group of muscles are just jerking and contracting. They could also have focal tonic seizures, where a part of the body, maybe a limb, or maybe the trunk is just stretching out, or a generalized tonic seizure. They could also have myoclonic seizures, or even just spasms, just small contractions in different parts of the body. These neonates could also present with what we call motor automatisms, where they are not typical clonic or jerks or stretching. They could present just with ocular signs, where the child is just blinking, or oral, buccal, lingual movements, where the child just, as if the child is just having lip smacking or sucking movement. Then they could also have progressive movements, like in neonatal jaundice, in bilirubin encephalopathy, where they have all the cycling movements and breathing movements. And you could also have what we call complex purposeless movements. As the child is just moving, there's no pattern to the abnormal movement that the child has. So when you have all these kind of movements and they are coming recurrently, you should actually think of a neonatal seizure.
Okay, I think we are having more chats, more comments on the chat box. So let's just check. Okay, more people are trying to, answer questions to the teasers that we put up earlier. Okay, I think we're seeing some very wonderful contributions there. Hypoglycemia, electrolyte derangement. Okay, this one is further neonatology now. It's like further mathematics. Okay, based on the case vignette we gave, we didn't give any representations as per whether there was any electrolyte derangement, but there was an unrecordably low blood sugar, which could be the cause. There was asphyxia, there was hypoxia as well. SpO2 was 40%. So those are possible causes of the seizure, which when we sorted them out, the seizure actually ceased. So very wonderful contributions from our participants there. Well done. Okay, so we'll now try to look at the the different semiologies of these seizures. Dr. Chidima has already outlined the different types, has classified the seizures that we'll find in neonates. So let's now take them one after the other. We'll take our time to explain how all these subtypes of or subclasses of seizures can present, so that when you find one in your practice, you'll be able to identify and know what to do. So for subtle seizures, can have transient eye movements. See a child that just looks in one direction transiently, not like the paralysis of upward gaze, that it's fixed gaze and all. So when you have this transient eye deviation, like what you find in children with oculo cutaneous albinism, these horizontal rapid movement of the eye, could be horizontal, it could be vertical. So that nystagmus could be a subtle kind of seizure, but you find it happening. When you find it happening in a child that is not an albino, it doesn't have the hypo or depigmented hair or skin, you should think that this child might actually be having a seizure, or a child that is blinking repeatedly, not that there is any attempt at any visual challenge, or call visual challenge. You try as if you're trying to touch the eye. You see a child just blinking as if somebody is trying to actually touch the cornea and all that. Mounting, abnormal movements like rowing, swimming, bicycling. What you find in bilirubin encephalopathy, you see a child that is not jaundice, that is not having any signs of encephalopathy. Now, doing that cycling movement, swimming, rowing, pedaling, and all, you should think of a subtle seizure playing out. Now, there are other autonomic features like fluctuations in heart rate. You see a child that is not, it's not as if there's any sepsis or there's any pointers to severe anemia or whatever that could explain, this tachycardia. Think of a subtle, seizure, or you find hypertension or apnea. Sometimes you see a child that is 10 having apnea that you cannot really, explain. Just know that you might actually be having a seizure. Well, we are not saying that if you see a preterm, an A3 preterm that is having some apnea, that you should send for EEG. That's not what we are saying. We are saying that you've ruled out the possibilities of maybe apnea of prematurity, but you're finding apnea. Otherwise, maybe a term child or a child that has passed that stage where the maturation of the respiratory center must have happened. Think of a subtle seizure. And these seizures are more pronounced in preterm than full-term babies. So most seizures, as we saw in the epidemiology, we have more than 50%, 57 point something percent of them happening in preterm babies, very low birth weight preterms, than those that are 10, whose incidence is actually as low as 2.8 per 1,000 deaths.
Okay, so the focal clonic seizure type. So in this seizure type, you see the child having repetitive rhythmic contractions of muscle groups of maybe the limbs or the face or even the trunk. And this seizure can be unifocal, meaning just one limb, one area is affected, or multifocal. So you can see the child having rhythmic contraction of maybe the right upper limb, left lower limb, and all that kind of thing. And also it can occur synchronously, and then occurring in the maybe left upper and lower limb at the same time at the same rate, or asynchronously, like I said earlier, maybe left upper limb and the right lower limb in different muscle groups. It can either be on both sides of the body or just one side of the body. And one feature that's common to these seizures that you cannot suppress it with restraint, as in trying to hold down the limb, the seizure doesn't stop, unlike ordinary spasms, as in when you hold them down and it stops. So when you see this kind of seizure, when you see a child having focal clonic seizure, you should think of an epilepsy. Most of the time it's an epilepsy. Most of the time it's not maybe a non-epileptic cause, like maybe metabolic causes and electrolyte derangement. So you should go on to investigate this child further.
Okay, so one of the things that we need to understand at this point is that, myelination of neurons happen between 18 months, and by 2 years, you expect that to have fully happened. So when you find a child, a neonate, having, a kind of global seizures that, involves both sides of the body at the same time, at the same rate, most likely it may not be epileptic, because the ability of these nerves to send signal from one part of the brain to the other, has not been able to, will not happen at this neonatal age because of lack of myelination. So most times they present with focal seizures, but by the time you find a global affectation, like we saw in our index, then most likely there might be an underlying either infective or metabolic cause, as we also saw the hypoxia, the hypoglycemia, the asphyxia, and the sepsis, as it were, from the prolonged obstructed labor. So where I think at this point, those that have followed us keenly should be able to know when a neonate presents with something that looks more generalized, think more of non-epileptic seizures, unlike those that come with focal seizures that will point to a possible epileptic seizures. Okay, so we go on to describe the other subtypes of seizures that can be found in neonates. For focal tonic, you have sustained posturing of either single limb groups, that, for instance, maybe the right upper and right lower limbs are stretched out, or you find us, sustained asymmetric posturing of the trunk. The trunk has muscle groups that balance themselves on each side. When you see a child that is tilted towards one side, it means that the muscles on that side have actually contracted, as against a child that we have this normal posturing of the trunk, meaning that the two muscle groups are balanced out. So you see a child that is posturing asymmetrically, or a child that have sustained eye deviation, looking towards one side. In subtle, we say the eye deviation is transient, but when you find a child that is having sustained eye deviation, just know that that child is having a tonic seizure. And these seizures cannot be provoked by stimulation, neither could it be, suppressed by restraint. And once you find this kind of seizure, just know that you might be dealing with an epileptic seizure.
They could also have the generalized tonic seizure in these units. Like we had reiterated, when they would have sustained symmetric posturing of the limbs. So that means all the limbs are involved, as well as maybe the trunk and the neck. And they could be flexor or extensor. So maybe the child just folds up the limbs, maybe the upper limbs, the lower limbs, or they could be mixed, where there's extension, maybe extension of the lower limbs with flexion of the upper limbs. These seizures may be provoked or intensified by stimulation, as in when you touch the child, the seizures are more, and they may be suppressed by restraint or repositioning the child. When you change the position of the child, these seizures would stop. So in this, when you see this kind of seizure, you think more of a non-epileptic cause, like what we find in neonatal tetanus, you could see them that they could be provoked by sound, by light, or even by touch. And when you try to touch them, when you try to restrain, these seizures are restrained. So you think more of a non-epileptic cause, unlike in the focal seizures.
So for the other one, don't worry, we just be like, this one we are trying to describe different seizures. I think it's okay. So sorry for the breach in communication. We went offline a bit. We had a little network hitch. So I'll have to run over my clonic seizures again because of the little network downturn. Okay, for myoclonic seizures, they usually present as random, single or rapid contractions of muscle groups, which could involve the limbs. You find shock-like movements of the limbs, the face, twitching, or the trunk, having some shock-like movements as well. And this occurs within 1 to 2 seconds, and typically is not as repetitive as what you find in clonic seizures. Even if it recurs, it does so at a slower rate than what you find in clonic seizures. It may be generalized, focal, or fragmentary, or multifocal, if you like. That means different muscle groups are witnessing those shock-like movements at different rates. Not like a synchronized kind of movement. And it may be provoked by stimulation. These myoclonic movements, the reason why, this provocation may occur is, for cases of neonatal tetanus, for instance, you can actually have some of those shock-like movements noticed when, there is stimulation by touch, sound, or light. And so for them, the underlying pathophysiology might be epileptic, like what you find in early myoclonic encephalopathies, Otohara syndrome, or it can be non-epileptic, like when you find cases of neonatal tetanus. So just once you have myoclonic seizure, just know that it could be one of the two. So that means that you have to take a very good history, try to find out what the court care was like. There are people that still engage in harmful practices like using cow dung, toothpaste to care for the cord and all that. So when you find such history and find out when you examine there is actually some provocation, think of neonatal tetanus. But if you don't find such, then know that you may be having some neonatal epileptic syndrome, like Otohara syndrome, being responsible.
We could also have, like we had seen in the video earlier on, we could also have some spasms, which may be flexor or extensor, or in some cases, they could be mixed, where the child is having extension and then flexion at the same time. And these spasms may occur in clusters, as in the child is having it repeatedly in a day. Comes in clusters, maybe has up to like 20 of such spasms in an hour. And these are usually not provoked by stimulation or suppressed by restraint. When you find this kind of thing, when you can find this kind of spasms, you must think of an epileptic seizure.
Okay, so let's see. I think we're having more chats. Okay, people are still logging in with their names and email address. Once you've registered for the webinar, automatically the slides will be sent to you. So you don't need to write your name and email address on the chat box. So if you have questions regarding the presentation, so just drop them so that we can answer them as we go on. Okay, someone has tried to offer some prevention modalities for prolonged labor. Okay, prolonged labor due to perinatal asphyxia. Okay, this is one of the causes. Yes, that's very correct. Good antenatal care is a good preventive measure. Very correct. So thank you, Dr. Ezinwa, for that contribution. So we'll still get to the preventive measures as the presentation goes on. So when we get to the preventive measures, we'll be able to know some of the additional things apart from what Dr. Ezinwa has profiled that could also help, in preventing some of these presentations.
Like we had earlier talked about, the motor automatisms are other forms of the seizures, the ocular signs, like blinking, oral, buccal, lingual movements, progression movements, like all this bicycling, pedaling, complex purposeless movements.
Okay, so I think we need to dwell a bit on this slide. Now, these are some neonatal seizure syndromes, which when you find them, you may need to follow them up because they have some propensities of, presenting much later in life with, over to epilepsy. So the first of the 4 epileptic syndromes we have here is benign neonatal convulsions, also known as fifth-day fits. Now, these benign neonatal convulsions, a lot of researchers have tried to, profile some of the underlying etiologies, from viral infections to asphyxia to, electrolyte imbalances and all. But one characteristic thing about these seizures is that it presents between the 3rd and 7th day of life. Most times, most of them present on the 5th day of life. That's why it's called the 5th-day fits. Now, these seizures are benign. With or without any anti-epileptic drug, it will, resolve on its own within the first week of life. At most, maybe within the first 1 month of life, the seizures will cease. That's benign neonatal convulsions for you. Then for benign familial neonatal seizures, this one, is like the benign neonatal convulsions, starts within the first few days of life as well, usually between the 2nd and 3rd day, and resolves within the first 4 months of life. Within 1 to 4 months, it will resolve. But there is a characteristic EEG finding, which you see in the subsequent slide, what we'll call theta pontu alternans. You have an alternate, or alternating theta waves and spikes or sharp waves. So when you find such characteristic EEG, in a child that presents with seizure in the first few days of life, just know that you might be dealing with benign familial neonatal seizures. Now, the reason why, this familial was attached to the nomenclature is because there has been, demonstration of underlying channelopathies. Potassium channel and sodium channel mutations have been demonstrated, in these children. And when you find history of familial history of seizures in the parents when they were small, find parents that said, when I was small, I had these seizures. Doctor, just leave it, it will go. They may not be wrong. It might be benign familial neonatal seizures. So just know that this might be one of the epileptic syndromes that you can find in neonates. Then the other one is early myoclonic encephalopathy. Now, in early myoclonic encephalopathy, you have children that present with some seizures that are quite difficult to control, shock-like kind of seizures that starts within the first 3 months of life. And they have a characteristic EEG pattern we call burst suppression. Now, burst suppression, as you see in the subsequent slide, is actually, you find epileptic discharges followed by isoelectric or reduced neuronal activity in the brain. Once you find that, just know that you're dealing with early myoclonic encephalopathy. Now, encephalopathic in the sense that isoelectric this thing you're seeing means that that child might have some form of intellectual impairment, later. So they need to be followed up because some of them progress to what we call early infantile epileptic encephalopathy, where also known as Otohara syndrome, where you find a child with these recalcitrant seizures, with difficult to control seizures, followed by that will have the EEG tracing of burst suppression, just as you find in early myoclonic encephalopathy. In addition, they also have developmental delay. So when you see a child that is having some developmental, delayed milestone, neck control taking a while before it's achieved, sitting, crawling, standing, taking a while, then now find that they have seizures that are very difficult to control, and you do an EEG and find burst suppression. Just know that that child possibly has Okay, so when you find this kind of EEG tracing in a child, in a neonate, just know that this is a burst suppression. You see lines lying like this is like electric tracing. Then you find some epileptic discharges here. Isoelectric epileptic discharges, isoelectric epileptic. So this is what we call burst suppression. This is found in early myoclonic epilepsy as well as Otohara syndrome. And these are the children that will have recalcitrant seizures that when you give, the more you give them medications, the mother tells you, my child is still having seizures. So just know that these are, the kind of things you find in such epileptic syndromes. So you can always send them to child neurologists. We know how best to control the seizures. Okay.
So we'll now go on to talk about some of the causes based on the age of the child. Like in the first 4 days of life, the common causes are hypoxic ischemic encephalopathy from a child that has had a beta asphyxia. It could also be due to drug withdrawal, maybe some drugs that the mother was using, like use of narcotics or even barbiturates. Then drug toxicity, intraventricular hemorrhage, especially in the preterm. Then some acute metabolic disorders like hypocalcemia, sepsis, and even maternal hyperthyroidism or hypoparathyroidism, where the child could also come down with the hypocalcemia, and also hypoglycemia, like we saw in the index case that we talked about.
Unrecordably low blood
sugar in the first.
Okay, so other causes of seizures in the first 4 days of life include prenatal insults, prematurity, those that are small for gestational age, maternal diabetes. The maternal diabetes will eventually, make the, especially when there is poor control, the child gets a very high sugar supply in utero, and this will eventually lead to, release of high insulin in the child. So when the child comes out, insulin level is high, but that supply is not as high as it was in utero. So you now find that they will come down with hypoglycemia that will eventually result in, seizures. Now, other causes of hyperinsulinism in neonates can also cause hypoglycemia. Other metabolic causes, like hypomagnesemia, hypo or hypernatremia, iatrogenic. Sometimes we give neonates the wrong fluid. If you give them fluid that will predispose them to having high levels of sodium or low levels of sodium, they might come down with seizures. Even feeding, there are mothers that don't know how to constitute infant formula properly. Maybe you want the milk to last longer. You use 100 mils and put 1 spoon. Now, that can lead to hyponatremia that will make the child have seizures. Or maybe you want the child to get very creamy, milk. They wrote on the bottle, on the label, that 30 mils to 1 scoop. But when you mix it, if the milk is looking watery, you want to, add like 2 or 3 spoons for that, into that 30 mils, so that when the child eats, takes the milk, the thing go whole body well. So when you do those kind of things, there are very high sodium levels in some of those infant formula. So when you do that, the child might have hypernatremia that will eventually cause seizures as well. In developed countries where they have these inborn errors of metabolism, galactosemia, hyperglycemia, urea cycle disorders, and other inborn errors can also lead to seizures in the neonatal period.
So in older children, as in from the 4th day of life and above, the first 2 weeks of life, you now start thinking about infective causes like meningitis, bacterial, encephalitis, metabolic disorders like hypocalcemia related to the diet, like I said, milk formula, if maybe it's dilute milk, the child can have hypocalcemia and then seizures, and even hypoglycemia as well. Also, some other inherited disorders of metabolism. You should also think of galactosemia, fructosemia. So it's not normal to make a diagnosis of meningitis in the first 24 hours of life for a neonate that is convulsed. You must think of other causes, not infective causes. Most of the time, they start having meningitis from the 4th day of life.
Okay, so these are the other possible causes within the after 72 hours between the 4th day to 14th day of life. So then be around the 6th week, you think of your touches, infections, herpes simplex, head injury. When you find a child, a 2-weeker, coming to the hospital with seizures after 2 weeks, think of the possibility of child abuse, puerperal psychosis. Some mothers that, maybe the person that dropped the seed abandoned them and they go, wacko and all that. They might get so upset with the child, beat up the child or throw the child away, and that could cause head injury, that will cause intraventricular or intracranial hemorrhages that will, make the child present as seizures. So just have that at the back of your mind when seeing such patients. So you can also have, we've seen a couple of children that had congenital anomalies of the brain, cerebral cortical malformations like lysencephaly, focal cortical dysplasia, even neurocutaneous syndrome. You can have underlying structural pathologies in the brain causing recalcitrant seizures. So, but if you find some of those lesions of on the skin, you have to send them for imaging, studies to, identify whether there are some structural anomalies that could be responsible for their seizures as well.
So, like we've said earlier, neonatal seizures are relatively common, and they can present in diverse ways, like we presented earlier. So, and their presence is often the first sign of a neurologic dysfunction, either functional dysfunction or even maybe there's a structural anomaly. And they usually are powerful predictors of long-term cognitive and developmental impairment. So a neonate that has a seizure should be monitored at least on a long-term basis. Any developmental anomaly. Most of the time in neonates, seizures are focal, and they are rarely you could have some generalized seizures like we've explained earlier on.
Okay, I think we're having more comments on the chat. Let's see. Okay, say they can't hear us. We'll have to increase our volume. So, okay. Can you hear me now? I believe you should be able to hear me. Okay. Okay. So let's write down. We'll increase our volume so that you hear us better. Now, the investigations that you send these neonates, for depends on the underlying etiology. By the time you get a focused and detailed history, having examined them and all, you should be able to know which investigation modalities that that will be indicated. For our index, prolonged perinatal asphyxia, prolonged obstructed labor with perinatal asphyxia, the random blood glucose that was done was unrecordably low. At least that one was able to help us know the underlying reason why the child was having the seizures. Now, serum electrolyte urea and creatinine is important because hyper or hyponatremia can be responsible. Calcium and magnesium assay are important as well because low levels of this can also, cause seizures. Then the bedside pulse oximetry can help, those that are hypoxic that may benefit from oxygen supplementation. And once you do that, the seizures will cease. Then those that have inborn errors of metabolism, you do the indicated enzyme assay for the deficient enzyme. For those that present much later with seizures after the third day of life, you are thinking of meningitis, you can do your sepsis screen, you can do blood culture, CSF analysis, and all, which will also help you identify the causative agent and treat appropriately. Now, for those that have possibilities of structural defects in the brain, most preterms, we have to routinely do transfrontal ultrasound scan. It will help us pick those that are having intracranial bleeding. Yeah. Then those that have neurocutaneous syndrome or other possible structural malformation, cortical malformation, CT or MRI can also help. Now, I believe by now we should be able to know those that we need to send for EEG. It's not every child that comes to you that you say, go and do EEG. At least do blood sugar, do electrolytes. By the time you're able to rule out those common things that could have, eventuated in the seizure. And the semiology of the seizure can also guide you. Those that are having generalized seizure most likely may be having some metabolic derangements or sepsis being responsible. But those that are having focal seizures may be having epileptic seizures, which will require an EEG, test done for you to know the nature of the seizure and the best way to go about managing them. Okay, so
for the seizures, it's always important in neonates to identify what the cause is. Like in the case that we presented earlier, we saw that the child had unrecordably low blood sugar, also had hypoxia. So at least if you identify the causes and you take care of the causes, most of the time the seizures would wait. But if in the ones that are now epileptic seizures, as in the ones that you have identified that most likely maybe the ones that are having focal tonic, focal clonic, or even the myoclonic or the spasm, infantile spasms, those ones will require anti-epileptic drugs for management.
Okay, and the anti-epileptic drugs, phenobarbital, for most seizures, neonatal seizures, even if the seizure is from the village, once you give them phenobar, 5 milligrams per kg, 2 divided doses, it will control the seizures. But for the ones that are from epileptic syndromes, phenobar may not be able to control it. So we may need to go higher to vigabatrin, topiramate, levetiracetam. And for infantile spasms, those ones that are recalcitrant to some of these anti-epileptics, you might resort to steroids before the seizures are controlled. Okay, so we've talked about
all these
underlying
causes, and correcting the hypoglycemia, any electrolyte imbalance. If there's sepsis, you give antibiotics, oxygen administration if there's hypoxia, phototherapy, or if it's due to neonatal jaundice, if it's due to kernicterus, and then other underlying etiopathologenic factors. You treat any cause that you find, you should treat it.
Okay, so we've mentioned for breakthrough seizures, you can either use the diazepam 0.3 milligram per kg IV to abort the seizures, or IM paradihide 1 ml per year of life, or 0.1 to 0.3 mils per kg. So those can help control the breakthrough seizures. Then most commonly, phenobarbital, most times to control the seizures. If there is an underlying cause, while you're sorting out the underlying cause, you can just place on phenobarb a short course just for 5 days. Once the underlying cause is sorted out, you don't need to continue. But for those that are from epileptic syndromes, you may need to extend the anti-epileptics when you must have done your EEG, established the underlying cause, counseled the parents, on the reason why their child is having such difficult to control seizures. Then you can now, continue them on the long-term anti-epileptic.
So to prevent these seizures, general health promotion would help, like in health education, health education, exclusive breastfeeding because of risk of hypocalcemia, or even the hypernatremia form, inappropriate mixing of the breast milk substitutes, environmental sanitation, neonatal screening in places where it's done for all those inborn errors of metabolism, and then good antenatal and delivery practice. Like in our index case, the mother that had a prolonged obstructed labor
of 3 days,
and then after delivery, a child had the anesthesia, the child was still kept before referral. So those are things that will help to prevent the neonatal seizures. Then immunizations, food supplementations for the mothers. Then early referral, like we had talked about in our index case as well. And early diagnosis and prompt treatment. We can't make the diagnosis if we can't recognize these seizures, which is part of why we're having this webinar, for us to be able to make this diagnosis early and treat promptly. Then limitation of disability, neuroprotection. This is where, like, if it's child has birth asphyxia, you could use magnesium sulfate in some cases, or even the phenobarb.
Selective head cooling.
Which
has some neuroprotective effects.
Yes. Or even centers where they don't have, some people, what some people do is that you don't do active warming for babies that have birth asphyxia, so that's still do that neuroprotection. Then rehabilitation for the ones that now have maybe neurological sequelae from these seizures. They will require physiotherapy, maybe the ones that have speech delays, speech therapy.
Okay, so I don't know if we have other comments. Okay, what's the marker for hypoglycemia? Is it 40? Okay, for the different people use different. In 40 milligram per kg, universally is taken as a cutoff, but it will be criminal for you to keep this chart and say you're waiting for it to go below 40. Some places, once it's below 50 milligram per day, they correct. So you don't wait until there is a neuroglycopenia, seizures, before you start doing something. And for there to be neuroglycopenia, it means that hypoglycemia has been there for some time for the brain to have started complaining. When you're holding somebody, the person might just use the fear of God and remain there. But by the time you hold the person down for long, the person will now kind of react or respond. So once it's below 50 milligram per kg in a neonate, please Correct. Don't wait until it goes down. Okay, so I don't know if there are other. Okay, we can't hear you. We can't hear you. We allowed enough. So I don't know. Maybe next time.
Earlier.
Okay, okay, that was before. Okay, so for prognosis, most neonatal seizures, have very good prognosis. Most children that will have seizures within the neonatal period don't end up having seizures or epilepsy later in life, save for those that have underlying channelopathies or underlying structural problem anomalies like Otohara syndrome, like your tuberous sclerosis or Sturge-Weber syndrome. Apart from that, most children with neonatal seizures have very good outcome. In fact, there's a study, I think the next slide, tries to highlight, okay, this is a study that was done. There were two groups that were, they monitored over a 24-month period. Those that one group received anti-seizure medications. This ASM is anti-seizure medication. The ones in black got anti-seizure medications for that length of time, while this other one, did not continue the anti-seizure medications, on the neonates that presented with seizures. And there was no statistically significant difference in the outcome, in both groups, both those that were maintained and those that were not maintained on anti-seizure medications didn't have epilepsy later in life. So this will help us realize that, neonatal seizures most times will not lead to eventful neurologic sequelae later in life. So I think that explains the good nature of the prognostic index of children with neonatal seizures.
So as we conclude, I want to reiterate that neonatal seizures are important pointers to neurological disorders in newborns. And then early identification and prompt treatments can help to limit the morbidity and even mortality, and also improve their outcome.
Okay, so, and from us here, Living Children's Hospital, we believe, is our belief that by the end of these presentations, our objectives have been met. I believe that everybody that participated actively in this interaction should be able to recognize neonatal seizures when, parents present their children with one. And we should be able to also know the possible, underlying causes of these seizures, having gone through the myriads of possible etiologies. And when they do present to us, we should be able to manage them. It is not rocket science. Those that present with hypoglycemia, we should be able to correct it. Those that present with hyponatremia, we should be able to sort it out. Whatever be the underlying etiology of these seizures, we should be able to identify and manage them appropriately. Okay, I don't know if there are questions, comments, and feedbacks. At this point, we can actually take questions. Okay, wonderful presentation by resource persons. Thank you very much for a beautiful presentation. What is the place of monitor in neonatal seizures? Okay. What again? What is the place? This is the same question. Presumptive correction in macrosomic babies. Okay. How do we correct hypoglycemia? Okay, so I think we can answer some of those questions. Let me start with the use of monitor is actually controversial. A number of people, there are people that use it you know that the more a child has these seizures, the more there could be cerebral edema from repeated seizures. So one school of thought believes that part of the neuroprotection we are preaching is actually helping to reduce this edema, especially those that have had. If I find a child that presents with repeated seizures following perinatal asphyxia, I will offer the child IV mannitol, 1 gram per kg over 30 minutes to be repeated 8 hourly, at least 3 doses. That's personally, although some people will not want to give mannitol because of some of the pitfalls or drawbacks of its usage. Now, the correction of hypoglycemia, okay, we've agreed that you don't wait until less than 40 before you correct. So when you do want to correct, what is in the books and what we do might actually be, in conflict. The books will say if there is no neuroglycopenic symptoms, use 200 milligram per kg. If there is neuroglycopenic symptoms, 400 milligram per kg. But the most important thing is to ensure that this child's blood sugar is, within the normal range. Whatever works for you, you can go ahead and do that. But we here at Limit Children's Hospital, we don't just do 400 milligram per kg for correction. We also consider the fluid the child was on. Now, if the child, was actually getting 12.5% dextrose, for instance, you don't correct with 10% dextrose, because that's what is in the books. You also do the correction using, factoring in the fluid that the child is on. Because if the child is on the mountain and you want to, correct with a valley kind of this thing, of course, that may not work. So we consider not just the strength of fluid now, but also look at the strength of fluid that the child was initially on. What was the other question again? The other one. Oh, okay, yeah. Okay, the preemptive correction. Okay. Well, for those that are macrosomic, you don't even need to wait until they present with hypoglycemia. Those that that are more than 4 kg, as they are coming out, you ensure that you maintain the glycemic level, either by feeding them or by setting up IV fluid. Yeah. So as they are coming out, you don't even need to wait until the sugar level drops. Just calculate the glycemic need of the child, 6 to 8 milligram per kg per minute. Just calculate, know the best fluid to use, or ensure that whatever oral feeds you're giving will give you that calorie requirement. So that's what we do here, and it has been working for us. So maybe you can just give it a try. I believe that a trial will convince you. Okay, so thank you. In the absence of any other question, I want to thank all our live and virtual participants for making this presentation a successful one. Thank you, and from my colleague, say thank you. Okay. Okay, the CME certificate will be sent to the email address that you registered for this webinar with. Thank you. God bless. Have a wonderful day.
The Limi Children's Hospital is a multi-specialty children's hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.